Which of the following that we studied here is our intermediate filament except is the question. So which is not an intermediate filament? That's the question asked. So let us look at this. What are these intermediate filaments? What is their function? Intermediate filaments are proteins which are present in the cell, basically cytoskeletal proteins. So they are cytoskeletal proteins and function is to increase stability of the cell basically. So they will be the one which will increase the stability of the cell. So various cells, almost all cells will be having these intermediate filaments. So which is not? Cytokeratin, desmin, vimentin, ecadherin. Answer to this question is ecadherin. Let us look at what are intermediate filaments. Let us have a look at them. Intermediate filaments are, different intermediate filaments are lamin. Do not confuse, this is not lamnin, it is lamin. Lamnin is your ECM protein. It is not lamnin, lamin here. So these are present in the nuclear lamina of all the cells. After that, there is one more, vimentin. Vimentin is also an intermediate filament which is present in mesenchymal cells. Next is desmin, which is also an intermediate present in muscle. So if you look at this, we use these also as markers for tumors arising from those cells. For example, desmin is used as a marker for tumor arising from muscle, leiomyomas, rhabdomyosarcomas, for all of them. Next, neurofilaments are present in axons of the neurons. Then GFAP, glial fibrillary acidic protein. GFAP is present in the glial cells around the neurons. Next is cytokeratin. Cytokeratin is present in almost all the epithelial cells. So that is why cytokeratin is used as a marker for carcinomas as well. Next, question number 2, the second one. A 50-year-old male is known hypertensive and diabetic, came to casualty. So he is a known hypertensive as well as diabetic. He has come to casualty with complaints of weakness on the left side. On examination, he was found to be dead later. So basically, he is having weakness and he is dead. A medical autopsy was ordered and the cardiac tissue showed very characteristic. They have given boxcar nuclei. Boxcar nuclei in the cardiac tissue is nothing but feature of hypertrophy of the myocardium. So this indicates hypertrophy. It can be commonly seen in HOCM. This patient is unlikely to be HOCM or maybe HOCM also. We do not know unless you give me a history. 50-year is fine to have HOCM. HOCM would have been from beginning itself, but only death could have occurred at that point of time. But however, I would not suspect HOCM because he is a hypertensive. I would suspect hypertension because that is hypertension is the one which is leading to hypertrophy, left ventricular hypertrophy. So answer to this question, option A, cardiac hypertrophy. Atrophy in cardiac muscle is not the answer. If you find atrophy, there will be brown pigment inside them. Senile heart also the same thing. In MI, there will be loss of nuclei. That is why answer to this is option A. Next, question number 3. This is a one-liner and it's a fact-oriented. 18-year-old patient presents with a renal cell carcinoma. Usually, very important, RCC is not in 18 years. Usually it occurs in elderly, not at 18 years of age. Now, given that this tumor typically occurs in old adults, which of the following genetic or which of the following translocation you might find in this patient? That is what is the question. So basically, young patient having this tumor, so which mutation are you likely to find is the question. Yes, RCCs in young usually are rare, but if they occur, that is what we call them as X17 translocation. So option B is the correct answer here. So what is that? Translocation X17. X17 translocation, this leads to formation of a gene called as TFE gene. So X17 translocation leads to, so there's a TFE gene and that TFE gene is responsible for this, and these patients will have morphologically features of both papillary carcinoma as well as clear cell. So there will be papillary architecture seen along with clear cytoplasm. So they will ask this question, XP11 to 17 translocation will have a architecture of both clear cell carcinoma of kidney as well as the papillary carcinoma of kidney. Next, question number 4. A 60-year-old man presents with sudden onset of left-sided paralysis and facial weakness. On examination, he was having increased muscle tone, hyperactive reflexes. So basically he is having hyperactive reflexes and there is a left-sided paralysis. The most consequence of this disorder are as a result of damage to which of the following cell type? Labile cell, multipotent progenitor cell or permanent cell. So, or stable cell. Basically this patient is having a stroke, and in stroke there is damage to the neurons, and these neurons are permanent cell. That is the correct answer here. A 35-year-old woman presents with endometrial carcinoma. So she is having endometrial carcinoma, 35-year, young age for that. Her mother died of endometrial cancer at the age of 40. So very important, mother died at the age of 40, and her that too with endometrial cancer, and her brother was diagnosed to have colonic carcinoma when he was 42, and he was FAP gene negative. So basically brother is having colonic carcinoma, mother was having a endometrial carcinoma, and she's also having the endometrial carcinoma here. So what is the likely answer in this? So basically from this history itself, I can tell this is a familial carcinoma. Which familial carcinoma? We have to check that. It is familial. And is it because of APC? No, because FAP was negative, mutation was there. So it is not. WT1 also not the answer. WT1 is associated with Wilms tumor. So it is nothing to do with Wilms here. So that is also not the answer. MSH and BRCA. BRCA mutation can be associated with endometrial carcinoma, commonly associated with breast as well as ovarian. So that is also not the answer. MSH2. So this is actually HNPCC. What is HNPCC? Hereditary non-polyposis. HNPCC is hereditary non-polyposis colorectal cancer, HNPCC. And the syndrome that we call with this HNPCC is the Lynch syndrome. That's called as the Lynch syndrome. So patient is having Lynch syndrome. What are the criteria? There's a criteria to call the Lynch syndrome, and you can refer to this in the explanation. 3 or more relatives should be having tumors. Which tumors? Either it should be a cancer of endometrium, small bowel, transitional cell carcinoma of ureter or renal pelvis, and there should be at least 3 relatives should be there. One of them should be first degree relative, and other 2 in whom familial adenomatous polyposis has been excluded. So very important, you have to exclude out FAB, then only you will make a diagnosis of HNPCC. So question number 6, we are talking about all of the following are seen in Fragile X syndrome except is the question. So what is not seen in Fragile X syndrome? Which is not true about Fragile X is the question. Mode of inheritance is X-linked recessive. That is a true statement because Fragile X syndrome is the one which has a classical X-linked recessive inheritance with few exceptions. Exception include your unfavorable ionization, and also the males can be carriers here. Causes mental retardation. This is also a true statement. In fact, this is the most common inherited cause of mental retardation. That is what is Fragile X syndrome. It is not the Down syndrome. The most common inherited cause of mental retardation is Fragile X. Downs is not inherited. Most common genetic cause is Downs. Mutations occur due to FMR1 gene. That is also a true statement. Option D, this is not the true statement. So answer is option D. Genomic imprinting occurs in the classical ones that we can give Angelman Prader-Willi syndrome, and then we can give Beckwith-Weidman syndrome as well as Silver-Russell syndrome, not in a Fragile X syndrome. Next question, let us look at the next question here. A 39-year male presents with anemia, lymphocytosis. So the patient is having anemia and is also having lymphocytosis, showing atypical lymphocytes, majority of them deeply clefted nuclei. So the nuclei are having clefted nucleus, means this is the nucleus and the nucleus shows a cleft like this, deeply clefted nucleus. Next, further what does it say? Let us look what does it say further. Immunohistochemistry shows kappa restricted cell. That means they are B cells basically, and they are maturing B cells. Kappa restricted cells, CD20 positive, CD20 positive, 19 positive. So it's a B cell lymphoma. CD10 positive, BCL2 is also positive. So the moment BCL2 is positive, I am suspecting query, or even 10 is also positive, I am definitely thinking of a germinal center lymphoma. Because it is BCL2 positive, I can suspect a follicular lymphoma as well. Let us look further. What does it say? Ki67 is low in favor of follicular lymphoma. Why? Because the other germinal center lymphoma include diffuse large B cell lymphoma and also Burkitt lymphoma, which will not have low Ki67. So answer to this question. So now look at this. Even without looking at it, it cannot be hairy cell leukemia. It cannot be ALL, because ALL will be having dark condensed nuclei. That's one thing. And apart from that, ALL will also have markers, not only CD10, they should be TDT positive. It cannot be CLL. It is follicular lymphoma. Follicular lymphoma is the second most common lymphoma in adults, and it's a low grade lymphoma. Indolent is the course is indolent. Now look at this. This is the next question is a simple one. Wider RDW is seen in which of the following? It's a one-liner one. Thalassemia, sickle cell anemia, megaloblastic anemia, PNH. We all know that RDW indicates, if it is wide RDW, that means there should be lot of anisocytosis. So if you're finding lot of anisocytosis, which is the likely diagnosis here, it cannot be thalassemia. All will be microcytic there. It is not sickle cell anemia as well. It is not PNH. Answer is megaloblastic. Wide RDW is seen in extreme variation. The best answer, if at all that was there, best answer would have been a dimorphic anemia. That is not the case here. That is not given, and that's why I will go with megaloblastic. Megaloblastic will also have a wide RDW. Yeah, normal RDW, we all know that in standard deviation, it is 39 to 46 femtoliter. In coefficient of variation, 11.5 to 14 or 11.6 to 14.6, that is given here. That's all fine, right? Just remember that in very chronic and severe vitamin B12 or megaloblastic anemia, it will become less. RDW will become narrow. Yeah. Next question. This is again a one-liner question. FOXL2 gene mutation is seen in which of the following tumors? Look at the options. Granulosa cell tumor, clear cell carcinoma of ovary, immature teratoma, seminoma. Basically, other three things are, tumors of the ovary basically. Teratoma can be anywhere. So answer is basically this is coming from a genital tract question. Answer to this question, FOXL2 gene mutation is characteristic of granulosa cell tumor. Remember this, granulosa cell tumor, especially adult granulosa cell tumor. Yes, so FOXL2 stands for fork head transcription factor basically, and this is a transcription factor, and this is responsible for, I already told you, adult granulosa cell tumors. It is seen in adult granulosa cell tumor, and it is uncommon in juvenile granulosa cell tumor. Remember this. It is not seen in juvenile. It is only seen in adult granulosa cell tumor. Now, next question number 10. Let us look at this question, and slightly confusing by many students, and let us see the question here. Resolving power of a light microscope is not affected by, it is not affected by sample thickness, focal length of the objective, wavelength of the light, numerical aperture of the lens. Now, So let us understand this few things. Although I have given it in the explanation, I want to explain it in my terms here. So the textual word, I can explain it better on the screen here. Let us look at it. So what do I mean by, first we need to know two words. One is resolution and resolving power. These are two different things. They are not same. Resolving power and resolution. First let us talk about resolution. Is nothing but 2-point discrimination. 2-point discrimination is resolution. So what do I mean by 2-point discrimination? To see 2 points separately. Now I have drawn 2 points separately here, A and B, and one more I am showing C and D. So these are, let me say this is microscope 1, this is microscope 2. Microscope 1 can show us A and B separately. Microscope 2 can show us C and D separately. So that is what I mean. That is what is your resolution. So microscope 1's resolution is distance between A and B. Microscope 1's resolution is distance between A and B, and microscope 2's resolution is distance between C and D. So this distance is called as, represented as a D. Now obviously greater the D, that means if there are more, if there should be more distance between two objects to be seen, that means the microscope is not better. So the first microscope is better, by the way, right? So D is actually, resolution is the distance between the two objects which can be separated by a object lens basically. Now resolving power is inversely proportional to D. Remember this point. Resolving power of a microscope is ability to discriminate basically. That means it is inversely proportional to D. So now let me talk about how is this D dependent on. This D is dependent on, we have a formula. Some people also call this as D min, by the way. So I have a formula given in the explanation as well here. So look at this. What is the formula for D? D is equal to 1.22 lambda divided by numerical aperture. So let me write it, 1.22 into lambda divided by Na, where lambda is equal to wavelength of the light used. So longer the wavelength, more will be D. So if more D is there, then what is the problem? So will there be a problem? Longer the wavelength, D will be more. Yeah. Longer the wavelength, there will be more of D. And if the D increases, the resolving power decreases. So wavelength of the light, definitely yes, it is question asked is. So in this, is resolving power dependent on the wavelength of the light? Answer is yes, it is dependent on wavelength of the light. Let us look at other things now. What is this NA we say? Numerical aperture. Now numerical aperture roughly corresponds to amount of light. Basically it is amount of light collected by the lens. See, basically your microscope is a lens system, and more the light it collects, better will be your resolution. That is what it says. So basically what is numerical aperture here? Numerical aperture is amount of light collected by the lens. So let us talk about this a little bit here. So let me say this is your lens. Let me draw one lens here so that we start understanding this better. Let me say this is your lens. Now this is your lens I am drawing, and let me say this is your stage where you are keeping the slide. So let me draw, this is your stage. Let us say this is your stage. Yeah, this is your stage, and let me say this is the slide that you have kept on the stage, the black one, right? So now look, very important is when we are talking about, now little bit of optics has to come here. Let me start drawing one ray of the light that is going from beneath. So what is happening is, this is a ray of light that I have drawn here, and this ray of light, assume this is a straight one here, slightly tangential, doesn't matter. So now this is a ray of light that has happened. Now basically what will happen is, whenever the light is passing through this, will there be refraction happening in the object itself, that is in the slide itself? Yes. So there will be some amount of, so when the light is hitting, let me draw multiple rays so that we understand this better. Look at this. Now the multiple rays I am drawing here. This is one more. Now look, this is one more. and let me draw one more here as well. So what will happen is all of them will not pass straight. Basically all these light will not be passing straight. Now what is going to happen here? Yes, now so there will be some amount of refraction happening. Let me say this ray undergoes a refraction here. So let me say it goes like this. If it goes out of the lens, it's not going to help me at all. One more, let me draw with a red color now. Let me say this is one more light which goes like this. Now whichever light is going like this, is it collected now? Answer is yes, this light is collected. So basically now look at this. So one more ray, let me say it is going like this. From here it is going like this. Now look, the red arrow is of no use for us. Why? Because that's not being collected by your lens system. So there will be an angle that is created. This angle is theta. So this angle is theta. Now very important is, of course, the same theta will be on this side also, by the way. Anyway, we will not discuss that. Now what is the numerical aperture will depend upon this. Now numerical aperture, if you look at our formula here, the numerical aperture is n sine theta basically. What is n sine theta? N is the refractive index of the medium here. N is equal to Ri of the medium. Ri of the medium between your slide and the lens. Obviously that is air, and for air it will be 1, by the way. If you are using oil immersion, it will be more, around 1.47 is the oil for oil immersion, and sine theta. So basically it is dependent on this angle theta and also the Ri of the medium. So very important is, now look at this, what is going to happen, or what are the questions. So is it depending on the numerical aperture of the lens? We know that it is, yes, it is dependent. Now what about sample thickness or focal length of the objective lens? Answer is it is dependent on sample thickness as well. Why? If you make the sample thicker, if you remember, numerical aperture is nothing but amount of the light that is being able to be collected by the lens. If the sample becomes thick, less light passes through the sample. That is why less light will be collected by the lens as well. So that is why answer to this question is, so you need not get into the whole mathematics of this. Don't worry about it. You need to understand the concept. Option is B here. Next, question number 11. Let us look at this next question here. What is this? A 52-year-old male presents with history of allogenic bone marrow transplant from a matched sibling donor, performed in a reference hospital due to acute myeloid leukemia 1 year before. So he had a bone marrow transplant 1 year before. The patient started having oral and skin lesions. After bone marrow transplant, oral and skin lesions, I am going to suspect GVHD basically. Why? Because there can be ulcers and skin lesions, even jaundice also can be there, and also diarrhea, etc. can be there, right? GVHD I am suspecting here. Now, which of the following investigation is the investigation of choice to rule out GVHD in this patient? Now, very important, GVHD diagnosis is not, GVHD diagnosis is two. One is clinical suspicion and second one is biopsy. Alone biopsy will also not help, but anyway, we have to do a biopsy. That is the answer. On biopsy, what will you see? So of course it is not other things, mixed lymphocyte culture, HLA cross match, nothing, right? Now on biopsy, what do you see? There will be depth of cells. Basically the T cells will be infiltrating into those organs and killing them. So on histology, there is increased eosinophilia. If we remember, it will be a irreversible cell injury. Vacuoles, apoptosis can happen, and lymphocytic infiltrate, and this lymphocytes will be predominantly T lymphocytic infiltrate. Next, question number 12. So let us look, what is this? Which of the following is true regarding Kikuchi-Fujimoto disease? So, okay, it is most commonly affecting axillary node. It is most common in young males than in females. An increased T cell mediated response. Lymphadenopathy resolves over several weeks to months. Now, which is true has been asked. Very important, Kikuchi's disease or Kikuchi-Fujimoto disease, some people short form it KFD, also known as subacute necrotizing lymphadenitis. So basically it will be a lymphadenitis, and this is a self-limiting disorder, most commonly affects the cervical node. So it is not the axillary node, that is wrong. Patient will present with cervical lymph node. It affects usually females, very important. It is not males, it is females, young females. And usually it is thought to be an increased T cell response. That is what is going to happen. And yes, lymphadenopathy resolves over few weeks rather than months. So it is not going to be weeks to 6 months. It will be only within few weeks. So that is why answer to this is option C, an increased T cell mediated response. Right. So similar to Kikuchi, there is one more disease called as Kimura's disease. What is this Kimura's disease? Kimura disease is also a lymphadenitis, also sometimes called as ALHE, angiolymphoid hyperplasia with eosinophilia. So there will be a blood vessel in the center of the lymph node. There will be hyperplasia of this blood vessel as well as lymphoid hyperplasia with eosinophilia, Kimura's disease. Okay, this Kimura's also presents with lymphadenopathy in young people. There will be a lot of necrosis. It comes as a DD for Hodgkin lymphoma even on biopsy, because there will be plasma cell, there will be eosinophils also seen. Yeah, this can the Kimura disease can also have cutaneous lesions, and that is how it presents, lymphadenopathy, cutaneous lesions like that. Question number 13. Oncocytic cells in thyroid are seen in papillary carcinoma of thyroid, Hashimoto's thyroiditis, Riedel's thyroiditis, medullary carcinoma of thyroid. Oncocytic cells. Oncocytic cells of thyroid are nothing but your Hurdle cells. So where do we see Hurdle cells then? Hurdle cells. So straight away answer now. Option is Hashimoto's thyroiditis. These are metaplastic cells of thyroid, Hurdle cells.